Okay, so it's 6:30, so we'll get started. Good evening, everyone. Thank you all for coming and welcome to the first of our five-part mini-series, the A, B, C, D and P of anaesthetics. My name is Mason and I'm one of the events officers for the Pre-Vocational and Anaesthetics and Critical Care Society, an interest group for students and junior doctors interested in all things anaesthetics and critical care. So tonight's topic will be on airways, and we hope to keep this short and sharp. So you can all get to dinner on time, and we'll have a brief 10-minute question time at the end. So please submit all your questions on the Sli.do link. Before we continue any further, I'll just pass it on to our sponsor for tonight's talk, who's David from MIGA. Go, David.
Thanks, Mason. Thanks, everyone, for the opportunity to sponsor your events. I hope that I'm not too interrupted by hail in the background. It's wild weather today in Melbourne. Yeah, so my name's David. I've been with MIGA for 10 years. And I guess it's quite a pertinent point as to why I decided to work for MIGA, because I'd come from 10 years working for a teachers credit union, which was a member-owned organisation, not-for-profit. And when I was looking around for another job, that's what attracted me to work for MIGA. So I think that's quite an important point for everyone to know, that it is a not-for-profit member-owned organisation that exists just for your benefit. So MIGA has been around for 120 years, and all we've done in that time is medical indemnity insurance. The not-for-profit status, or being existing just for your benefit, gives us the ability to invest money back in the services to give you better services. So the key one that you get, I think, out of us being a not-for-profit is the medico-legal support. So being able to ring up and speak to a lawyer at any time of the day or night is an amazing benefit, and probably undervalued a little bit by doctors because and medical students, because the cover's been free in your student years and in the junior years for doctors, and they haven't really, realised how amazing it is that you can ring up and speak to a lawyer at any time. We're lucky in the industry to have the most experienced legal team. Cheryl McDonald, famously, our head of our medico-legal team, has been with us nearly 25 years. Second in charge, Antti Manello, 17 years, and most of the others longer than 10. As I said, I've been here 10 years myself, and I've seen one retirement, and all the rest of our lawyers are all still with us that were here when I started. So no one's even left and changed employers in that time. So it's an amazing group of lawyers on hand for you. When you think about, on average, they take about 5,000 calls a year across the team for advice from our members. Over that time, in Cheryl's case, in 25 years, she's had probably every scenario you could probably think of, and gives us enormous confidence when talking to you, knowing the level of advice you would get over the phone when you need it. So yeah, it's you and Gina Reinhardt that have a lawyer on call 24/7, but she probably pays $5 million a year for it. And you guys get it included in your free student membership, which is a pretty amazing deal. So your insurance with MIGA is free until halfway through your third year as a doctor. So for some of you, I guess it's going to be another 7 years of free cover or something from here, which is pretty good value. We're, I think, the only insurer that don't make you re-sign up again at intern time. So I've just been ringing our HMO3s and getting a few shocked responses that people didn't realize they were still members because it'd been free for so long. So that's something to be aware of. Why do you need insurance? Well, obviously, especially once you're a doctor, if a patient sues, you want to have someone who's on your side. So in that scenario, the hospital's got their insurance. In the case of Victoria, through VMIA, the patient will obviously have their lawyer through who they're using to sue the hospital or yourself, and so you need someone who's just on your side, and that's where your indemnity provider steps in. So it's a really good way of thinking about it, that the hospital insurance isn't there for you, it's to protect the hospital for your actions, probably similar to the uni insurance. So this is something that was started by doctors, exists just for your benefit. Now, we also give you a great product for free, and there's some things that we cover you for, like your rounds and Good Samaritan Acts on top of your standard complaints to APRA and those sorts of things. And 1 in 5,000 students get a complaint to a medical board, and you might need our support to write a letter to so that, legally, the wording is there to protect you as much as possible. And certainly something that we've seen over the years is some pretty frivolous complaints against medical students. I think one got complained about for a loud party because the neighbour knew they were a medical student, so they thought there was somewhere they could complain to about them. So that was a pretty frivolous complaint. So MRGA is, as I said, free till halfway through your third year as a doctor. Sign up now, get used to being educated about what it is all about. We've also partnered with Qantas for frequent flyer points. So once you've signed up, head to our website to get a free Qantas frequent flyer membership valued at $99.50 because there'll be points waiting for you in the future when you're a doctor. And so it's good to grab that free membership now while you're a student and get used to earning some Qantas points. So thanks very much for your time tonight, everyone. Enjoy your meeting, and we'll see you at the next event. Thank you.
All right, thanks so much, David.
Thanks, Mason.
Okay, so now I'm delighted to introduce our speaker for tonight's event, Dr. Bridget Bishop. Bridget graduated from the University of Melbourne in 2015 and spent her intern and residency years at the Austin before being accepted onto the anaesthetics training program in 2019. So currently she's a third year anaesthetics registrar in the Northwest training scheme, currently based at the Mercy Hospital. And outside of medicine, she's a proud parent of Lucy, her Labradoodle, and enjoys scuba diving and skiing in her free time. So thank you, Dr. Bishop, for spending a Tuesday night with us. I'll pass it over to you and let you share your screen.
No worries. Thanks, Mason. I mean, it's a long time since I've been able to go skiing or scuba diving, but yeah, we'll see. Hopefully that day will come. Mason, I'm just trying to share my screen, but you've disabled participant sharing. So if you could fix that up for me, that'd be great. Thank you.
That should work now.
Cool. Yeah, that should work. Let me. Hopefully this works. Why isn't this working? Cool. Can you see that okay?
Perfect. Awesome.
All right. Excellent. Great. I'll try not to waffle on for too long, but as an anaesthetic registrar, Airway is certainly my area of expertise. But I'm mindful that you guys probably have some better things to do on your Tuesday night. And personally, I definitely want to go watch Survivor later, so I won't take up too much. Now there's going to be a Q&A through Sli.do. Mason, will you be manning that?
Yep, we'll do. I'll collect some questions.
Yeah, great. Cool. While I can do an anaesthetic and play Scrabble, that's the limit. The Airway, and then we'll go through some cases. And when it comes to management, I'll share with you some things that I think are really important, particularly for junior doctors to be able to do, because I think every doctor, particularly working in a hospital, should be able to manage the basics of an airway, because it does take time for help to arrive sometimes. I've definitely been in situations like that as a junior. So without giving too much away on that little holding slide there, just throwing it out to the floor. Can anyone please share with me what we can see on assessment of a patient's airway and what we might be looking for?
I suppose if there's any obstruction to their airway.
Yeah, and what would you see clinically in that situation?
Maybe like if there was vomit in their airway.
Yeah, great. So you might see some secretions or vomit. Yep. And if the airway is completely obstructed, you might actually see them trying to make respiratory effort against an obstructed airway, which looks like seesaw breathing. And you can sort of replicate that in yourself. If you sort of block off your nose and your mouth and try to breathe, your chest wall muscles will move, but you're not shifting any air, and it creates that real seesaw kind of breathing. And we can see if the airway is not obstruction, that there is chest rise and fall, because if the patient is breathing, the airway must be patent to some extent. That's great. What about some things that we can maybe hear when examining our patient? Yeah, I can see some people in the chat have said Sli.do. Yep. So Sli.do is airway obstruction from the proximal trachea upwards. So that might be, the proximal trachea, larynx, sort of upper airway. What if you don't hear any Sli.do, you know, that the breathing is quiet? What could that indicate? So someone said the silent chest for asthma. Yep. So that would be, I guess, more in a breathing sense. And what we're concerned about there is bronchospasm that is so severe that there's no air entry in the chest. But yes, a complete occlusion. So the silent breathing can either be completely patent, which is great, or completely obstructed, which is bad. Okay, so beware the quiet airway. There. You might also hear some snoring, which would be related to the pharynx being partially blocked by the tongue or the soft palate, and gurgling, which might suggest fluid. I think someone mentioned vomit earlier. So you might also hear air passing through some, you know, fluid that are in the airways. So yeah, when assessing a patient from an airway perspective, we look, listen, and feel. And I didn't cover feel, that's that last one. You know, you probably remember that from your ALS or BLS training, where you know, put your I guess in pre-COVID times, put your head close to the airway to see if you can feel, or you can put your hand there and feel if there's any airflow. So yeah, really using your eyes and your hands, you can make a really quick assessment of a patient's airway. Now, what about some common causes of airway obstruction? Like, why do patients get airway problems? Thick neck, perhaps that's a polite way of saying obesity, which goes hand in hand with something called obstructive sleep apnea. So if you've got an obese patient, they can get airway obstruction. I've seen a lot about foreign body. Yep, so there can be foreign matter in the airway, either like an inhaled peanut or fluid or vomit or bleeding. Hematoma is a good one. So the blood can be a problem when it's bleeding into the airway, but you can also get hematomas, say, for example, after, say, neck surgery, which can swell within the neck and then cause airway obstruction. So that's a lot of physical things I'm seeing there. I see anaphylaxis as well, so assuming that's angioedema. That's, yeah, hanging injuries, yeah, that's all physical things. Yeah, so CNS I can see has just popped up there as a big one. And certainly in my line of work, I think conscious state is the biggest cause of airway obstruction. So consciousness is required to maintain tone of the upper airway muscles. So with a reduction in consciousness, either from anesthesia or sedation or from drug abuse or a head injury, that reduction in airway muscle tone can cause airway obstruction. So let's go on to the next slide to see if we got all of those. Yeah, so I put CNS at the top because in my line of work, certainly that's what I see as the most common cause. Anaphylaxis and hematoma would be in the sort of swelling umbrella, foreign bodies, masses, and fluid and such as blood or vomit. And I've certainly, I think I've encountered basically all of those. Yep, I've had a cashew in the airway, I've had vomiting, had anaphylaxis, yep, all of the above. So that's a good list there. All right, so moving on. So now this is, I think this is the meat of it really. I think this is what I really want you guys to take away from it. When we talk about airway management, we categorize it into airway maneuvers, so simple things you can do with your hands. There are airway adjuncts, which are things that you can use in conjunction with that. There are airway devices, which are things that we can actually insert to better support the airway. So what are some of the airway maneuvers that are available to us, things that we can do with our hands? Head tilt, great. Yep, there's 3, so head tilt, chin lift, and last one, jaw throw. Excellent. And so would very much encourage you when you've come through to do an anaesthetic term or even on a surgical term to come and have a go at doing some basic airway maneuvers on a real anaesthetized person because it's good practice. Is there a patient population where a head tilt and chin lift would be contraindicated? C-spine injury. Yeah, excellent. Good. And yet someone has said children. Yes, the airway maneuvers that we do in children are slightly different because their airway anatomy is different to the adult. And generally you don't need a head tilt for children. So the jaw thrust, I think, has to be one of my favorite airway maneuvers for two reasons. One, it does open up the airway really nicely, lifts the jaw forward, brings the tongue off the back of the palate, but also it's incredibly stimulating. So if you put your own fingers behind your jaw and push, you'll see that it's actually really quite painful. And because in my line of work that conscious state is a common cause of reduced airway tone, by doing a jaw thrust, not only am I opening up the airway, but I'm stimulating the patient and increasing their level of consciousness. And there's certainly been a couple of code blues that I've been to where the patient is obstructed, and by doing a jaw thrust, I open up the airway and kind of wake them up, which is really helpful. All right, so let's see, did we get them all there? Yep. So they're the airway maneuvers: head tilt, chin lift, and jaw thrust. We mentioned C-spine injury to avoid the jaw thrust. MILS stands for manual inline stabilization, and that's maybe a bit beyond the scope of this talk. And then just to cover off the basic maneuvers, there are things you can do to manage fluid and sort of foreign bodies. McGill's forceps are scissor-like devices that have got a right angle on them, and you can use them to grasp things, and there's suction as well. I would just advise you to not put anything into a patient's mouth beyond the point where you can see it. You always want to be able to see what you're doing. And just be mindful, do not put your fingers in somebody's mouth. They may very well bite down and bite your fingers. So leave that to the McGill's forceps and the suction. Great, all right. So what is next? Alrighty, so there are airway maneuvers. What are some basic adjuncts that we can do? So I guess presumably we've got a patient who's needs airway management. We've maybe got a bag valve mask on, we're doing a chin lift and jaw thrust, head tilt with the mask, and we're still struggling with two hands. What are some things we can do? Yeah, absolutely. So we've got an oropharyngeal airway, otherwise known as a Goodell's, or a nasopharyngeal airway. So the Goodell's are those plastic devices that go into the mouth. In a child, you just pop it in the way that it sits, whereas in an adult, you start it with the tip facing up, run it along the back palate and plop it in. They come in green, yellow, and red as small, medium, and large in the adult sizing. But, sometimes they can be quite challenging to put in if the patient's, not opening their mouth, if they've got trismus. And so nasopharyngeal airways are a good option too. Making sure that you lubricate them up nicely. Any patient populations we need to be careful of a nasopharyngeal airway in? Trauma, yeah, base skull fracture, yeah. So you don't want to do a spinal tap through doing, a nasopharyngeal in somebody with a head injury and base skull fracture, because you might introduce like infection into the cerebral spinal fluid, or shove something that shouldn't be there. The other patient population would be people on anticoagulants. You just got to be mindful of the risk of epistaxis. And if you're having a difficulty with airway management and then you cause a nosebleed, that will make it worse. And what I mean by that is patients that are on anticoagulants, somebody on 100 milligrams of aspirin a day, I wouldn't worry about. But yeah, just something to be mindful of. And I guess that leads me to a general tip that I tell a lot of students and juniors that I work with. Anesthetics is a lot like Lego. If it doesn't go, don't force it. So if you're putting in a nasopharyngeal and you're feeling a bit of resistance, stop, or you'll do a turbinectomy. And yeah, no one will like that, including the patient. Great, so we've covered those there. And I would certainly encourage you all to be confident and comfortable selecting and inserting oropharyngeal and nasopharyngeal airways. I'd be very impressed if I arrived to a code blue and that had been done. That's really good. There are other more advanced techniques, include laryngeal mask airways, which is a type of supraglottic device. They're advantageous compared to an endotracheal tube in that they don't require much skill to put in. There's no laryngoscopy or anything, you just shove it in. It's kind of like a glorified Goodell, really. The first generation ones are the classic, they're probably the ones you've seen the most, they're those floppy ones, and the second generations have got a port for a gastric tube that you can put down, and they're supposed to sort of seal the esophagus a little bit better, allegedly. And again, certainly, I think this is well within your scope as a junior doctor to put in an LMA in somebody who's in trouble from an airway perspective. Of course, the biggest disadvantage is that it doesn't protect the airway from any secretions because it is supraglottic. And so the definitive airway is an endotracheal tube, which is something that I would be a bit upset if a junior doctor attempted without the skill. That is something that you would save for anaesthetics or intensive care or the emergency department people. But at the same time, it's nice to know what that is. So we use a laryngoscope to insert the tube into the airway, and we inflate a cuff below the cords, which will then protect the airway from secretion. Sorry, I just knocked my mouse in and it went wild. Surgical airway is listed there. So that is a sort of a front of neck access option. And again, this would be in a can't intubate, can't oxygenate scenario, where, you know, we're trained to do a cricoid thyroidotomy. So basically the cricothyroid membrane we puncture with a needle or a scalpel to get an emergency airway. And thankfully I've never been in a situation like that. Any questions about that stuff? Because that was quite, I guess, information dense. Any questions about airway devices before we move on to some cases? Okay, I will take that as a no. So we'll just move on to a case. All right, and I really would love participation to be through turning on your microphone and having a chat for this one. So we have a 65-year-old previously well man in ED with right lower lobe pneumonia. These observations are there on the screen, and for community-acquired pneumonia, he is started on ceftriaxone and azithromycin, so that person's obviously looked up the therapeutic guidelines, which is great. And shortly after the ceftriaxone has been administered, the patient complains of difficulty breathing and the saturations drop to 85%. So would anyone like to hazard a guess as to how they might assess and manage this patient?
I think in this case, I'm concerned about anaphylaxis.
Great, good. So what will we do?
I suppose in this kind of acute situation, I'm concerned about his airway with an upper airway obstruction. So probably assess for angioedema, maybe assess for signs of shock as well.
Yep.
But ultimately, he needs some adrenaline.
Yeah, great. That's excellent. So, and this, I guess, is one of the challenges of transitioning from medical school to actually working, is that you really don't do history, exam, investigations, management in that order. You do a lot of simultaneous assessment and management. So that's great. You have identified that the definitive management is adrenaline. So 500 micrograms IM, or you can give intravenous boluses of sort of 10 to 20 micrograms at a time, thereabouts. But definitely give it IM to start with, because it'll act as a depot. And then an A to E assessment and management, identifying issues and managing them as you go. And because this is an airway case, we've got difficulty breathing and low saturations. So that will be an issue that we'll have to manage, but also recognizing that anaphylaxis is a multi-system issue, so that there will be, possibly some hypotension that we'll have to be dealing with too. And adrenaline's great because it will reduce any sort of swelling and angioedema. It will reduce the bronchospasm and cause bronchodilation. It will help with the blood pressure by causing vasoconstriction and increasing cardiac outputs. But ultimately, adrenaline is great because it actually stabilizes the mast cells and stops further release of histamine. So adrenaline. I'm sure in this situation, you yourself would be coursing with adrenaline, but I'm afraid you will still have to crack an ampule to give it to the patient. So we're examining the patient, stridor, angioedema, signs of shock. Great, nailed it. I guess the other thing we should mention is we've got a call for help. So this would be potentially a peri-arrest situation. So calling a code blue would be appropriate in this setting. Great. Now we later check the patient history and they're allergic to penicillin. I guess just on that note, if the patient had, because this comes across up in anesthetics all the time because we give cefazolin for surgical prophylaxis. If a patient is allergic to penicillin and the reaction is a rash, safe bet that the cephalosporins will be okay to give, but this is obviously just very unlucky. And, if they were anaphylactic to penicillin, I probably wouldn't have given ceftriaxone, but there you are. These things happen. Great. Any questions about that case at all? I might ask the PVACCS guys to check the Sli.do and see if there's any questions about that case.
No questions as of yet, Bridget.
All right, cool. So we will move on. So in that case, managing the patient's airway was, really around managing the primary cause of the airway problem, and then, supporting as needed. All right, so our next case is we've got a 23-year-old male brought in by ambulance with a GCS of 8. There's no medical history. There was a discarded needle found nearby when he was found in his car. So we examine him, we see that he's got respiratory depression. So he's got a low respiratory rate. He's hypoxic with that. We see that he has pinpoint pupils and he's a bit tachycardic. We can hear some gurgling in the airway. So we're doing our look, listen, and feel. We can hear some gurgling. We can look and see some vomit. He's got crackles. He's got track marks. Would anyone like to please share what they think is going on and what management the patient needs? Anyone like to speak up?
So in this setting, we are concerned of drug overdose, specifically opioid overdose, potentially heroin, due to the pinpoint pupils. So in this setting, we want to take an ABCD approach. So firstly, assess the airway, stabilize the airway. So maybe, I think if it's GCS 8, we might want to think of intubation. In addition, we want to give naloxone to reverse that. So potentially like a 400 microgram bolus or something IV or IM if that's necessary. And then, just oxygenate, ventilate, and maybe suction out any vomits in the oropharynx prior to intubating. And then I think that would be the best first steps. If they are a bit tachycardic or hypertensive, maybe an IV fluid bolus might be helpful too.
Excellent, great. So we've said that this is possibly an opioid overdose, the definitive management for which is naloxone, and then the A to E assessment. Certainly I agree that if he's GCS 8, he's will probably need definitive airway management. And this is a good opportunity to share that not only does reduced GCS cause issues with the airway in terms of reduced upper airway muscle tone, But the other problem is that it does put the patient at risk of aspiration if they have a full stomach. Again, because of the reduced upper airway muscle tone, there is a reduced ability for the patient to protect their airway. Their cough reflexes are diminished, and therefore there is a higher risk of aspirating any gastric contents. So yeah, this patient would require what we call a rapid sequence induction and intubation. Rapid sequence induction means to give predetermined doses of a hypnotic drug and a muscle relaxant in order to rapidly achieve unconsciousness and paralysis to facilitate quick securement of the airway via intubation. And you're right, definitely need to have suction on hand for that. So yeah, this is yeah, pretty dicey situation, and the fact that he's got coarse crackles on examination of the chest suggests that he maybe has already aspirated. Great. Fantastic. All right, well, we're on to the last, I think, sort of section of the talk in terms of cases. This isn't a case necessarily, but it's just a point of discussion regarding airway management in trauma. So trauma can cause airway problems through its effect on GCS in terms of head injury, but also there can be direct trauma such as mandibular fractures or trauma to the neck, you know, fractured, not only a fractured neck in terms of the C-spine, which would require immobilization and a collar, but, you know, there are injuries that can occur to the trachea and to the larynx, which require specialist management. So yeah, that's sort of a special population when it comes to airway management, and again, probably a little bit beyond the scope of our talk for today. But just bearing in mind that it's a special population. Great, well, that's the sort of slide or didactic part of the talk today, but I think sort of the more interesting things can come from what questions you might have. And I might throw it back to Mason to field any questions, I guess, both about airway management and the cases, and then if we've got time, some general sort of anaesthetic career stuff, if you like.
Cool, thank you so much for that. So I've got a few questions on Sli.do. Thanks to everyone who submitted questions. The first one is in anaphylaxis. I'll just post it into the chat. Actually, it might be easy for you, Bridget. If you...
Yeah, that's a really good question. So in anaphylaxis and you're by yourself, you know, how much do you do before moving on? Absolutely. So I think that rapidly putting in a Guedel and 2 nasopharyngeal airways would be useful, and then oxygen. I would actually probably choose what's called a non-rebreather mask. It kind of looks like a Hudson mask, but it has a reservoir bag on it, and it allows for near 100% oxygen delivery through the reservoir, sort of more like 80%, whereas a Hudson mask can only deliver about 40%. So if you maintain a patent airway with the Guedel and the 2 nasopharyngeals, and then you've got 80% oxygen through a non-rebreather mask, if the patient's spontaneously breathing, that should be sufficient to move on. The definitive management will be intramuscular adrenaline, and you'll find that a lot of your problems in anaphylaxis will start to improve with the administration of adrenaline. Yeah, so I guess that answers that. Because yeah, putting in a Guedel nasopharyngeal and whacking on some oxygen is quite a hands-free approach. I guess another thing you could do, depending on your situation, is positioning the patient. So if they're flat on their back, I guess that's great for a blood pressure perspective. But if you can afford a little bit of head up, get the pillow in underneath their shoulders, you can kind of get them into a what we call the sniffing the morning air position, where they're in a bit of a sort of chin tilt just from their position in the bed. So, but obviously in anaphylaxis, we're trying to contend with blood pressure and airway. So it's probably going to be like a 30 degrees kind of situation, depending on that. Great. There's something also here, a comment about putting an LMA in. Yeah, I mean, I think it depends on the situation, but certainly in a code blue kind of peri-arrest situation, the thing is, if the patient doesn't necessarily like need an LMA in terms of an airway device, they won't let you put it in, right? If the patient's consciousness is such that you know, they'll tolerate nasopharyngeals, but they won't tolerate an LMA, then you won't be able to put it in because they won't let you, they'll bite down. And that comes back to the, you know, if it doesn't go, don't force it thing, right? But if the patient is arrested and it's a code blue, and it's, you know, code blue because of hypoxia, you know, by all means. But I guess the challenge is that you know, that those LMAs are going to be in the crash cart, which are going to be attached to the ICU and anaesthetic doctors that are coming with it. So, but yeah, definitely seek opportunities to practice putting them in. I love calling the medical student over in theatre who's on their surgical term and going, do you want to come and help with induction and then do the surgery stuff? So certainly take those opportunities.
Here's a second question, Bridget, for you.
Yep. I see one about, so there was something about intubation earlier in anaphylaxis. So to intubate a patient, you need them to be unconscious. So I wouldn't, I would, in terms of a patient having anaphylaxis, it's going to be pretty bad for them to be so unconscious that they require intubation. So hopefully with early recognition and early administration of adrenaline, that you would avoid that kind of situation. I see your point about airway swelling, but again, early adrenaline should stop that from being an issue. I see what you mean though, you're sort of wondering if we should take the opportunity sooner rather than later. I think that would be a sort of a case-by-case kind of situation. Great. And on the topic of adrenaline, we've got someone asking about the doses. Yeah, adrenaline, the way the concentrations are so annoying. So there's 1 in 1,000, which is a milligram in a mil, and that's a small ampule. And then there's 1 in 10,000, which is a milligram in 10 mils. So that's 100 micrograms per mil. So if you're going to give some IM adrenaline, you're going to be getting out the 1 mil, which is 1 in 1,000, which is a milligram, taking half a mil of that and giving it IM. Thankfully, the little ampule does say 1 in 1,000 on it, and then it says 1 milligram. So generally, as a general rule, any ampule of adrenaline that you pick up is going to have a milligram in it. It just depends if it's in 1 mil or if it's in 10 mils. Yeah, so that's that. Can you use an oro or nasopharyngeal airway in a conscious patient? So short answer, no, because they wouldn't tolerate it. It'd be quite uncomfortable. However, you can have patients with reduced consciousness who respond to different levels of stimulation. And certainly most patients with reduced consciousness would tolerate a nasopharyngeal. As you can imagine what that would feel like, you know, feel free to, after this, you know, put your finger up your nose, see what it feels like. You'll see that you can tolerate that. Whereas an oropharyngeal reflex, if the airway, if the gag reflex is intact, it wouldn't be tolerated. So that's a sort of a it depends answer to that question. Going back to adrenaline, what's the advantage of 1 in 10,000? So that's when we are in a cardiac arrest situation and you want to push a whole milligram peripherally. So it's just good to have 10 mils to flush in as the 1 milligram dose in an arrest, followed by a saline flush. the other reason we use it is to dilute it further for other uses. So you can dilute it further for infusion, for epidural top up for a Caesar, things like that. So it's just another dilution that's available. And I imagine they use it in peds as well, because the doses of adrenaline used in children would be lower. So having the more dilute solution would be easier to manage. Do you want me to just keep looking at the chat, or have you got someone's on Sli.do there? Or
I think that's all the time we've got, unfortunately. But on behalf of PVACCS and everyone attending tonight, thank you so much for your presentation. It was incredibly engaging, and I'm sure we've taken a lot from that. And to everyone who attended, thank you all for coming. If you enjoy that, Dr. Bishop will be again presenting next Tuesday for the next part of our mini-series on B for breathing. So you can save your questions for then. And sorry that we couldn't get to all the questions. I saw some career questions as well, which looked great. And we'll be having a careers night as well, where you can ask those. So we have many more events coming this year. So I'd encourage everyone to like our Facebook page and sign up for membership. It's completely free. And this session is recorded, so we'll upload it and send it to all of our members. So thanks everyone, and thank you again, Bridget, for that wonderful talk.
Yeah, no worries. Thanks guys, have a good night.
Bye everyone, have a good night.